Next, it's my pleasure to invite Dr. Pramod Reddy. Pramod is very much my partner in this India initiative, this India endeavor, this India project that we have started. For me, this is already my 10th year, though I came, as I mentioned, even earlier than that when Dr. Desai invited Dr. Reddy, Dr. Sheldon, and I got to tag along as a junior guy with many of the big names of pediatric urology and really help with be there, have a ringside seat as pediatric urology began to emerge as a subspecialty in India. And since then, Pramod has been my partner in all of the initiatives that we've done in India. He, as many of you know, is the director of pediatric urology at the Cincinnati Children's Hospital, one of the large and most well-known prestigious children's hospitals in the United States. He's also a professor of surgery or urology at Cincinnati Children's Hospital. Very well known in the field, a respected authority in fetal surgery, fetal urology, and urological reconstruction. Somebody I'm proud to call my friend, and an expert in the field, and whose talk I'm sure you'll enjoy on the strategies for optimizing outcomes of pediatric renal transplantation. Pramod.
Thank you, Assem Bhai, for that very kind introduction. Cho, hope everyone's doing well this evening. I want to thank all of you for coming out this evening. I know it's been a long and busy day. We've been keeping you all rather tied up with all of the stuff that we've been doing, and I appreciate all of you coming here this evening. I'd like to thank Mahesh Bhai for inviting us. This is our 11th year that we've known each other and have become better and better friends year after year, and almost feel like this is coming home. So thank you, Mahesh Bhai, for that hospitality. I'd like to thank the team that comes with me here. This year we celebrated the 10th anniversary of the collaboration that Dr. Atul Thackeray, Dr. Rich Grady, and Assem have put together. And when I look at all of the work that we're achieving as a surgical collaborative, it's pretty phenomenal. And the enthusiasm that we get, the smiles of the children that we're able to participate in their care along with you and the doctors in Ahmedabad, it just warms our heart. And I just want to say thank you for allowing us to come back year after year and be part of your team to help these children. What I thought I'd do today is just share some observations. Obviously, I can't, in the time allocated to me, teach you how to do pediatric transplantation, but what I wanted to do was talk about some of the things that we have learned as we are doing more and more complicated transplantations into children with dysfunctional lower urinary tracts. So I don't have any disclosures to make. As urologists, we are called upon to take care of a number of different disease processes that can end up in the child having end-stage renal disease. In fact, 40% of the diagnoses that we take care of, 40% of the children that progress to end-stage renal disease have a urological diagnosis as their underlying primary etiology for their end-stage renal disease, which is significant. And it is important that we understand how that primary diagnosis plays a role not only in their progression to renal failure, but how that might impact any transplantation that we put into their system. When we look at the outcomes of pediatric transplantation over the past decades, you can see now that we are achieving very, very good results. Our patient survival is about 97% over 5 years, and the 5-year graft survival is approaching 95% from living-related donors. These are incredible results when you think about the diversity of the pediatric patient. Because unlike an adult patient, the pediatric physiology is changing, their bodies are changing, and the demands that their body puts on that kidney transplant is changing. And yet we're able to achieve these results. And it's just a testament to our understanding of that physiology that these children have and working as a team. Now, this doesn't come without complications, and I think that we're the first to admit that in urology we do have a number of different complications that can occur. Some of them technical, some of them as a result of maybe underestimating the involvement of the lower urinary tract, and also some of them are just due to the disease process. But a lot of the urological complications do not directly relate to loss of the graft, But nonetheless, we should be very aware that we do have a number of things that we can control for and should be actively thinking about even before the time of transplantation. Probably one of the least understood issues is this concept of barotrauma. And the landmark paper by Dr. McGuire that showed that sustained bladder pressures above 40 centimeters of water are detrimental to the upper tracts. And I think that observation is probably misunderstood because people think, is it voiding pressure, is it storage pressure? It really is storage pressure. Sustained storage pressure above 40 centimeters is detrimental to the health of the upper tract. Okay, now that's in adult patients. What is that in pediatric patients? We don't know. We still use that 40 centimeters of water pressure, but we know it's actually much less. And it's much less for a teenager as opposed to even lower when you look at an infant. But we have not been able to do that clinical study because it would be unethical to subject patients to ongoing injury to their kidney while we're observing the pressures. Now it's interesting because pediatric patients, because of their lower blood pressure, that's why their kidneys are not able to withstand sustained pressures in their bladder. But they do have a pop-off mechanism, which is the lymphatics. And one of the things that one of my mentors, Dr. Curtis Sheldon, always taught me is that the transplant kidney is the most susceptible to barotrauma. And it's because we don't have intact lymphatics. So when you look at the risk stratification, it's adult kidneys, pediatric kidneys, and then the transplant kidney. The transplant kidney is the most at-risk kidney for bad bladders. So we have to always keep that in mind. And I'm looking at that, how do we explain that relationship between the bladder and the upper tract, right? So when we look at the pressure volume relationship, or Starling's laws, the normal curve right here is that we have a very low pressure compliant bladder that allows for complete volitional emptying. When we have patients who have reflux and they have a pseudo PVR, patients with voiding dysfunction where they don't empty their bladder all the way, their incremental voided volume as the bladder becomes more and more dysfunctional will become lower and lower. What I mean by that is they'll void a lower volume of their bladder capacity, leaving behind more and more of that post-void residual. And it's that post-void residual that actually keeps adding to their storage pressure because it never empties. So one of the things that we always want to be checking with our patients is how well are they emptying, what's their storage pressure, what's their bladder capacity in relation to the expected bladder capacity. And then also, one thing that we probably don't pay as much attention to is this whole concept of polyuria. Right? One of the first things that happens when a kidney gets damaged, it loses its ability to concentrate urine. So they make a significant amount of urine. During the daytime, these children can accommodate and void more frequently, but during the nighttime is when they get in trouble because they're sleeping and their bladders just become larger and larger as a result of that polyuria. So these are things that we have to be thinking about as we're assessing these patients. Now, one of the things that we can when we have a patient who's shifting to the right from the normal pressure-volume relationship and they're getting in trouble is to consider anticholinergic medication or augmentation to protect and move them into a safer range. So let's talk about that a little bit more. When we are called as urologists to evaluate a patient that's undergoing assessment for a upcoming kidney transplantation, we do have a little pathway that you can follow. The ultimate goal is to provide this child with a continent-compliant, sterile, evacuatable reservoir which is going to be safe to transplant into. All starts with a history and physical examination. In the history there are some certain things. You want to look at what is their voiding pattern. Are they frequent voiders? Are they infrequent voiders? Do they void to completion? Are they having urge incontinence? Do they have constipation? All these things are there so you can understand, is this child at risk for bladder bowel dysfunction, which can have an impact on their ultimate outcome with the transplantation. A good physical examination, sometimes we do have patients who have undiagnosed neurogenic bladders that may have actually contributed to the demise of their native kidneys. Routine screening, we do a ultrasound, VCUG to assess the anatomy and morphology of their bladder. And then in certain individuals, we will do selective investigations such as urodynamics. If they have reflux, I would suggest that you do a video urodynamics to really understand what is going on with that urinary tract. Because if they have high-grade reflux, your storage pressures and your actual volume are going to be underrepresented and overrepresented. And if we have patients who have hostile, at-risk bladders, we would suggest that these patients have their lower urinary tract optimized before you even get them to the point of transplantation. And oftentimes that will postpone or delay the need for transplantation because now you're prolonging the life of their native kidneys. So when we look at the lower urinary tract, you can divide them up into 4 bladder types. One is the normal bladder, good compliance, normal capacity, appropriate emptying, perfect, nothing to worry about. Go ahead and transplant it to that patient. But the defunctionized bladder, so if you had a baby who was born with high-grade reflux, was getting recurrent urinary tract infections, went ahead and did a vesicostomy, how do we get this patient ready for a transplantation? Then you have the dysfunctional bladders, where the dysfunction may be neurogenic, spina bifida patients, patients with posturethral valves who have myogenic dysfunction. Neurologically they're intact, but they have very bad musculature of that bladder that doesn't empty well and stores at high pressures. Prune belly, where they have big floppy bladders. And then, there is a whole category of others, the Hinman syndrome and high-grade reflux with the megacystis of reflux. So these are all categories that would fall under the dysfunctional category. And then you have that patients who have absent bladders, where their bladder may have been so poorly formed that they just don't have an adequate substrate within which you can transplant into. How do we get these patients ready for a transplant? Well, the patients who have significant oliguria due to primary upper tract disease with a pre-end stage renal disease normal urinary tract, you want to say, do we need to do anything about their lower urinary tract because it has not been cycling for the time before transplant by the time they were diagnosed with end stage renal disease? So we do say, ask a few questions. One is there any history of underlying primary bladder disease in those patients? The answer is no. Move on to the next one. Any history of any voiding symptoms? Do they have urge incontinence, urinary incontinence, nocturnal or daytime urinary incontinence? Any of these things that you can say, okay, maybe this is not as normal a bladder as we think it is. And then we do recommend a VCUG, or we used to, and I'll get to that in a second, we used to recommend a VCUG to understand what was the morphology of this bladder. We all know that the bladder, when it's not used, we're taught that it becomes dysfunctional and loses capacity and compliance. And one of the biggest things is that pyocystis, when you have a defunctionalized bladder that is never seeing any urine, is not being evacuated, there is a theoretical risk of pyocystis. But if they have no history of bladder disease, voiding symptoms, a normal VCG, and no history of pyocystis, you don't have to do any further evaluation. You can go ahead and transplant into that bladder fairly confidently. When you have patients who have a supravesical diversion where that bladder is truly defunctionalized, you have to prepare them for transplantation either with an undiversion or be prepared to transplant into that diverted bladder. And Dr. Canning a few years ago published a paper looking at the experience of CHOP with just this very thing. We used to be very concerned and move kind of timidly in transplanting into a patient whose bladder was defunctionalized with a vesicostomy. And now we know that actually the results of transplantation into vesicostomy are not that different. So, that has opened up a whole new arena where we can move forward with that. But what we try to do is to say, okay, so there was some pathology there. Can we rehab the bladder? Can we do active bladder management to get that bladder to be healthier before we transplant into it? And this can be, with intermittent catheterization, anticholinergics, or when we see that the bladder is not responding well, to move forward with reconstruction. So as I mentioned, one of the things that my colleague Dr. Vanderbrink and us, the rest of the transplant team, thought about, but Brian was the one that actually acted on that thought, was to say, are we actually doing too much investigation in these patients who are anuric? Do we need to be doing more or less? And so he undertook a retrospective review looking at a 10-year experience of patients who had isolated upper tract renal disease as their primary cause for end-stage renal disease. Anybody that had lower urinary tract dysfunction was excluded, and we defined anuria as 0 urine output prior to transplantation. And at the time of transplantation, all of our patients undergo a non-refluxing renal reimplantation. So when we looked at the impact of the GFR on the transplant kidney based on their duration of anuria and also time from transplant to 1 year after transplant, we saw that there was really no difference. The duration of anuria did not play a role in their ultimate outcome with their renal transplantation. So as a result of this finding that the majority of our patients in the pre-transplant anuria group with isolated upper tract disease did not have any significant bladder dysfunction, and the few that did responded well to bladder rehab with just some anticholinergic medication and avoiding retraining, we've stopped doing a significant assessment. So if their duration of anuria is less than a year, we don't do a urodynamics or VCG. We say that bladder will regain its function if we transplant into it. There was no statistical difference in the GFR at 1 year when compared to anuric or non-anuric patients, and there was no correlation between the eventual outcome with the duration of anuria. So this has really changed our practice, and I would just like to point out to all of the younger colleagues here, sometimes it just takes a very simple question or an observation to make a big difference. So please do not ever stop asking questions. Now, one of the big things is this whole concept of bladder dysfunction. There is, a lot of things that we think about when we think about bladder dysfunction, neurovascular dysfunction, valves, and prune belly syndrome, versus the secondary effects of those primary things: infection, retention of urine, need for surgery that causes its own ongoing issues, stones. And so let's look at that. I think before I move on onto our algorithm, one of the biggest changes in pediatric urology that's really revolutionized our ability to think in a more progressive manner about how we can care for these patients was the advent of the Mitrofanoff. Understanding that we can now make a continent catheterizable channel for these patients. So let's just move forward here for a second. And just in the interest of time. So I think that one of the first things, if you're looking at a young child you're getting ready for a transplantation, as you're being asked to create vesicostomies, ureterostomies, putting in a PD catheter, please keep in mind that this patient may at one point require a transplant kidney. So keep in mind where the transplant incisions are going to be located and plan your other incisions accordingly. So think ahead. Don't be selfish and just say, well, he needs a vesicostomy, I'm going to put it right here, right in the middle of where we might be going in future. The other learning that we have is that vascular access is not something to be taken trivially. So in our hospital now we have an improvement project where if anybody needs central vascular access and they have end-stage renal disease or are in CKD, chronic kidney disease stage 3, 4, 5, we have to have a consultation with nephrology to say what's safe and what's not, because we do not want to burn bridges for future hemodialysis access in these patients. So, lessons learned, take-home messages, in the pre-transplant considerations. One is that you want to try and optimize. Don't give up hope on the patient's native kidneys. Optimize the nutrition and the growth of these patients as they progress through. And sometimes in the babies, it is putting in a GT tube to help them with their nutrition, because these children, they don't have appropriate appetites. You want to maximize the health and function of native kidneys for as long as possible, because the results of transplanting into a young child versus an older child are very different. And you want to avoid preventable harm to that kidney, so avoid nephrotoxic medications and dehydration in these patients. We have an ongoing, again, quality improvement project where we have created a safety card for all of our patients who have CKD, so we give it to them, not only telling them what medicines they should avoid, but what medicines are safe for them to have, and also the impact of dehydration on a child who has chronic kidney disease. You want to mitigate and manage any underlying nephrotoxic pathology such as reflux or post-urethral valves. We do use antibiotic prophylaxis when required to prevent and reduce the impact of pyelonephritis. And then we do take into account the anatomic and physiological considerations about the native urinary tract. If there's dilating reflux, we may be prepared to take out that kidney at the time of transplant. We want to ensure that as we're preparing this patient for the transplant, that we're going to have them have a transplant kidney that's going to be implanted into a bladder that has adequate volume, appropriate compliance, complete emptying. We don't want to have any residual urine left in that bladder. And taking into account patient and parent factors, if they're unable to perform intermittent catheterization, maybe we should be doing a vesicostomy or an ileal chimney. And if there's a paucity of native bladder tissue, then we can augment them, do a conduit, or do a transplant with a ureterostomy or vesicostomy. We've done all of these, and we're still learning what's the best approach, but we're not afraid to transplant, because the shorter you can keep a child on dialysis, the better for them in the long run. At the time of the transplant, you want to plan for native, the plan should be there for what we're going to do with the native kidneys. Are we going to preserve those kidneys or do a nephrectomy? And if we are going to do a nephrectomy on the right side, we'll do that nephrectomy at the time of transplantation. On the left side, we do an interval nephrectomy later on if we see that this need's still required. We always do a non-refluxing reimplant of the transplant ureter. I know that the data on the adult side is not that strong one way or the other, but in pediatrics we feel that we should not do a refluxing reimplant of that transplant ureter. Stented versus unstented. Now there's some data that suggests that when you use a stent in pediatric transplants that you increase their susceptibility to beaky viremia. In our patients who have reconstructed urinary tracts, we will still leave a stent, but otherwise we're avoiding stents. And then again, the bladder management. How long do we drain this bladder after surgery, after the transplant, and when do we reinstitute intermittent catheterization if they were on it beforehand? So all of this needs to be discussed amongst the whole team ahead of time. Interval nephrectomy after the transplant, if we have urinary tract infections, continue the active bladder management program, because as we said, the transplant kidney is the one that's at risk from high pressures, and we want to mitigate that. And if they do have recurrent urinary tract infections or ongoing obstruction, the nephrology team and the transplant team know to refer that patient back to us in urology so we can once again be involved in their care. I think it's important to keep in mind the overall goal of all of us is to try and get this child back to a full life where they have minimized complications, urinary continence, independence, chronic depression if they are progressing through CKD can impact their overall sense of well-being that can affect their sexuality and how they feel about themselves. So we have a significant role in ensuring that this child gets back to their full potential. So we've got to work as a team. Thank you very much. Sorry.
Thank you. Thank you, Pramod.